Hi, I'm Dr. Matt Skalski, and in this video I want to cover the normal radiographic anatomy of the wrist with you. So let's just dive right in here and cover the standard views which we see in a minimum wrist series, which would be this view, the P to A view, the medial oblique view, and the lateral view. So as part of our normal wrist series, we actually do 3 views instead of our normal A to P and lateral views because that medial oblique view is often necessary to see throughout the arc of the wrist carpal bones. And often we will do supplementary views, including an ulnar deviation view, or if patients can't do that, maybe an angulated scaphoid view, and a few other ancillary views, which we're not going to go over here. But starting with the anatomy on the P to A wrist view, we have 4 carpal bones in each row, as you probably already know. We have our scaphoid, our lunate, our triquetrum with our pisiform overlying it anteriorly. We have our hamate, our capitate, our trapezoid, and our trapezium. All right, and so those are our different wrist bones. And I have a little scaphoid model I want to bring in here because the scaphoid is probably one of the more interesting portions of our wrist x-rays and the things that people are usually interested in, because many of the times we're taking a wrist x-ray it's because someone has a suspected injury, usually with suspicion for wrist fracture with pain in the anatomic snuff box. And so looking at the scaphoid here, it has a bit of anterior tilt to it. So we actually don't see the scaphoid laid out nicely on our standard wrist series because it is oriented a bit anteriorly on the distal side. It's a bit tipped forward here. And so we can see that it looks a bit broader too because of that, where we can see the proximal pole of the scaphoid kind of projects out here like this. And so we see this portion kind of overlying the fossa for the capitate, which comes in over here like this. And we can see that on the x-ray here even better perhaps. And so this is the articular surface for the radius. And then there's this bare area here, which in this person, because it's projectionally foreshortened, looks a bit smaller, which is a little bit more irregular in appearance. And then we have our distal pole with our articulation for our trapezium here, and then a little facet for our trapezoid as well. And then we come down here to our lunate, and our lunate is cup-shaped because it cups the capitate here. And so we see the depth of the center of that cup right here, and then the back edges kind of curl up and around along the posterior surface, and then the ventral edge here as well. This is our lunotriquetral joint right here. And our scapholunate joint, because of the arc of the carpus, we don't see it that well. So we see a portion of the scapholunate joint, but then it kind of curls out this way and we kind of lose it a little bit. So if we were to measure it here, we'd probably measure it about there. All right, and then like I mentioned, our lunotriquetral joint, we always want to scrutinize the base of our first metacarpal here. Occasionally we can have a Bennett fracture or things kind of hiding up there. And then, and so this is our proximal carpal row here. So we want to look through this arc. We want to look through our mid carpal row arc, which kind of extends along here like this. And then we want to look through the carpal metacarpal joint here, which is going to be aligned like this. All right. And then when we look down here at our radius, we have our radial styloid, and then we curve through here. And because of the slope of the distal radial articular surface being a little bit ventrally tilted, we see the dorsal rim of the radius kind of project up like this. And you can see that there is a little bump here, which separates our scaphoid facet from our lunate facet. And sometimes we'll see that better than others. And then this curls around here to our sigmoid notch of our radius with which articulates with the head of our ulna. And our ulnar head comes around here, and then oftentimes there'll be a little divot before we get to the ulnar styloid process. And we, in this case, can see the groove for the extensor carpi ulnaris kind of coming up this way. Often we will see the physeal scar where we used to have a growth plate for the distal radius, and then sometimes there'll even be a little overhang of the edge there where that, united, kind of leaving a little bit of a spur almost, and that can be a normal feature. In this case, it kind of transitions nicely in that region. All right, and so looking at the shape of the triquetrum here, I forgot to mention, I mentioned the lunotriquetral joint, and then this curves around, and then usually there'll be a little divot here before we get up to the lateral surface, and this is going to be the attachment site for our ulnomeniscal homolog, which lives in here like this. And then the rest of this space is going to be filled primarily with our triangular fibrocartilaginous disc proper. And this whole complex of things here, with a few other ligaments, is called the TFCC, the triangular fibrocartilage. All right, and so that's what's filling this. So we expect to see a void here on our x-rays because that's where our triangular fibrocartilage lives. And the triquetrum gets its name because it is triangular shaped like this with kind of 3 sides, if you will. I mean, still kind of 4 sides to me, but that's that. And occasionally the lunate here, this is a normal study without a variant, but occasionally the lunate will have a little facet on it here for the tip of the hamate. And because that, depending on how the wrist is structured, may articulate there, and that actually can cause some problems in some people having a lunate impingement. All right. So, and then one other thing to just point out here is that because of the arc of the wrist, we often don't see all of these joint spaces that well, particularly the trapezoid and trapezium joint, because of that overlap and just kind of the contour of the bones here. So this is not coalesced or anything like that. That's just how it looks. Similarly, you can have a similar appearance here with the hamate and the capitate because they do overlap a bit projectionally. And one other thing I forgot to mention was our distal pole of our scaphoid here I mentioned makes a joint with our trapezium and our trapezoid. So the fact that there's 3 bones involved in this kind of one joint, that's called our triscaphy joint, or triscaphy is kind of how that word is structured, or triscaphy is how we pronounce it. And then the other thing, which we don't see super well here, but on many P to A wrist x-rays, the hook of the hamate, because it points out straight anteriorly, sometimes that may just look like a circle here if you catch it kind of right down the shaft of it. In this case, it's kind of, we're seeing that curl of it a bit more, so we don't see it as like a perfect circle. All right. So let's talk a bit more about this scaphoid and kind of how foreshortened it is because of that tip. So you can see in this case, I've rotated around so it's kind of tipped towards us. And you can see that we can make out kind of the under surface of the distal pole here, and that can project across the waist of the scaphoid. And that's just because of the tilt. So if we look at the lateral view here, we can see how tilted this is, right? And so this is, I'm just going to try to roughly outline the contour of it. And so you can see that it's almost like at a 45-degree angle. And so again, because of that, we're going to see the proximal pole project out here, almost looking like it's coming out of the waist. And yeah, so that's what it's going to look like. So you may see this ring-shaped structure. And so the more ring-like it looks, of course, the more down the shaft of it you're looking, if you will. And so that actually can be concerning in some cases if it's abnormally tilted. But in this case, it looks normal, and we can always correlate that on the lateral. And then look at the angle between the scaphoid and the lunate. So if you look at the lunate here, it's kind of facing the tip of the cup is facing upwards. So it will hold water, if you will. I like to think of it as like a teacup. And so the axis of the lunate is here, and then the axis of the scaphoid is like this. And so if that angle increases, then that potentially could be, indication that this is actually tipped too far down. So that's our scapholunate angle, should be 30 to 60 degrees. All right, and so I mentioned, oftentimes we will do a supplementary ulnar deviation view, and part of the reason for that is that it allows us to see the scaphoid better. So this is the native position of the scaphoid, which I showed you on the first slide, where it's tipped forward a bit. But when we ulnar deviate, just physiologically, we apply stress and we pull it kind of into more of an upright stance like this, and it allows us to see it much better and see the waist laid out really nicely, which is often where the most often place we'll see a scaphoid fracture. And so you can see the radial articular surface comes up here and ends, and then we have this bare area up until we get to the trapezium and trapezoid articular surfaces. And so when you can see that bare area laid out really nicely, then you're seeing the scaphoid kind of lifted up, if you will, from that just the tension that's placed under ulnar deviation. And another thing that ulnar deviation is great for is because it also allows us to see the scapholunate joint a bit better typically, and it will apply some stress there. And so if it's the scapholunate ligament is incompetent or torn, then you'll see widening or diastasis at that site. All right. And one other thing I forgot to mention in the last view here, when we're looking at the ulna head, and it should sit here nicely in the sigmoid notch, and it shouldn't be too long or too short. That's an anatomic variant called, if it's too long, positive ulnar variance, or too short, negative ulnar variance. But we do allow just physiologically up to 2 millimeters of negative or positive ulnar variance, because that can change with how the x-ray is taken and patient positioning and those types of things. For example, when we take a wrist x-ray, oftentimes it's on a table, some distance below the shoulder. But to get true neutral ulnar variance, we would need to take the x-ray at shoulder level. and usually we don't do that. And so, when you put your arm down like that, it does apply a little bit of proximal tension on the ulna, which will cause up to 2 millimeters of physiologic radiographic shortening. So I drew that here, you couldn't see it. So proximal tension on the ulna. All right, so this one probably is under 2 millimeters. It looks like kind of on the fence, maybe a millimeter or so of negative ulnar variance. Okay, and again, we compare that, we'll follow down the main sclerotic portion of the articular surface, and we're measuring right from the edge of the sigmoid notch. So the edge of the sigmoid notch is here, so we draw that across and then compare that to the surface of the ulna. So that's how we're going to measure that ulnar variance. And if someone can't do ulnar deviation view for some reason, or we just want another shot of the scaphoid, we can also do a different view called an angulated scaphoid view, where you can see it looks nearly identical to the ulnar deviation view, but they don't have to be an ulnar deviation. And the way that that's accomplished is by taking that X-ray here and shooting it down at the scaphoid this way. Okay, and so if you instead of just shooting your wrist X-ray straight over like this, you shoot that wrist X-ray kind of tilted 25 degrees proximally, then we can look at the scaphoid the same way that we would look at it if it were tilted up like we get with an ulnar deviation view. All right, so sometimes what we'll see if someone's not positioned correctly, or maybe they just have to hold their hand that way from pain or whatever, is when the thumb is adducted here, the thenar eminence, the soft tissues, this part of your hand is called your thenar eminence. You can see, maybe just make my cam big here. If I bring my thumb over like this, it's going to create this really kind of thickened portion on my thenar eminence, and we can see that on here on the X-ray. So this isn't a mass lesion or anything like that. It's just because their thumb is adducted here, and it's further confirmation for that. You can see that their trapezium is kind of overlapping their trapezoid pretty significantly here, and the scaphoid is projected. The distal pole is pulled a bit more medially there as well. All right, so this is the medial oblique view, and this can be helpful for a lot of different things. It gives a bit different projection of the scaphoid. It allows us potentially to see joints we couldn't see. So if you look at the trapezium trapezoid joint and the capitate trapezoid joint here, when we do a medial oblique view, we're looking right down at that, so we'll often see those joint spaces really nicely. Gives us a better look at the ulnar styloid in some cases. And so this is a very helpful view, for a number of different reasons, just to give us a slightly different perspective on things. And even the base of the thumb here, we can see a bit better as well, perhaps. Oh, and look at this. We can actually see that little overhang at the physeal margin here. So very common to see that. And I often see, people who, when they first start looking at x-rays, they might think that's a fracture because it looks like cortical disruption. But as long as it's kind of continuous with a physeal scar there, we can be pretty confident that that's just normal for them. All right, so last here I want to talk about the lateral view. And the lateral view, I think, is the one people like looking at the least because we have so much anatomy superimposed. But it's actually one of the more valuable views. Well, I mean, they're all valuable, but there's actually a lot of assessment we do on the lateral. We had already mentioned that scapholunate angle. That's very important to measure. There's some fractures you can only see on the lateral, like a triquetral fracture. So let me just trace out the bones here for you. So this is our lunate. Okay. This is our triquetrum. We can see the dorsal cortex of it here, and then maybe we can see it overlying a bit like this. And then the scaphoid here is kind of overlying the lunate, and then it comes up like this and down like this. And so this has been lovingly referred to by myself as the duck, right? So if I just draw an eye on here and then say this is the duck's beak, the lunate's the wing, and then the triquetrum is kind of its tail back here, right? So there's our duck. And so when you have a fracture of the triquetrum, that's going to appear back here as a little fragment, and that's called the pooping duck sign. I'd like to claim credit for making that up. I was the first one to ever put it on the internet. So many people say that I made it up. I wish I could have been smart enough to make that up, but I didn't make it up. But I usually get credit for it. So if you want to blame it on me, then that's fine. Pooping duck sign of triquetral fracture. All right, so those are the bones of the proximal carpal row. The pisiform, which we can see up here as well. And this is actually partly how we determine how well positioned the lateral is. The anterior cortex of the pisiform here should be about halfway between the capitate and the scaphoid. So a scaphoid here in purple, the capitate anterior surface here in yellow. So the pisiform, let me just trace that out a bit better here. you want right in the middle there. And this is, you know, a perfect lateral if that's our metric. Some people might say, well, maybe it's a little bit pronated here because the triquetrum is projecting a bit posteriorly, and that's actually desirable. We want to see the triquetrum just slightly posterior because otherwise we might miss a non-displaced triquetral fracture. You know, if the duck's not pooping, but it's just got feathers on its tail, you know, we still want to see that. So let's outline the capitate here, and the capitate should be sitting nicely right within this cup of our lunate. Okay, it's almost like a mortar and pestle, if you will. And so you want these to be nicely aligned as on one mechanical axis. So the axis of the lunate facing upward should be lined up nicely. If the lunate is, you know, rotating around posteriorly or in front of the capitate, that could be because the wrist is flexed or extended. You know, that's the normal physiologic motion. But if we have a nicely positioned lateral and that rotation is happening, now we have some ligamentous instability potentially. And so the angle between these two should be less than 30 degrees. So, you know, 0 to 30, anything more than that, then we know that that lunate is abnormally tilted. And again, you know, you can't really make those measurements accurately unless we have a good lateral. So we often, you know, look at that pisiform cortex up here to see if it's, you know, in the midway between the scaphoid and the capitate. Usually we'll see the ulnar styloid process projected a bit more posteriorly here, and again, that can kind of depend on their wrist positioning. The radial styloid up over here, and then again, you know, it's kind of sloped downwards, and so we see the edge of the sigmoid notch down here like this. The capitate, oftentimes we'll see a little bump back here, and, you know, potentially that can have even an ossicle, a carpal boss, you know, a dorsal prominence, and we'll see that sometimes make a joint with the base of the third metacarpal. All right, so that is most of what I wanted to cover for the lateral, and just to show you a few different laterals here and how they're positioned, you can see that this one, the pisiform, is projected way out here anteriorly, so they're actually supinated a little bit. Their hand is tilted, you know, a little bit more towards the dorsum, facing towards the cassette. We can see everything else we need to pretty well, but you can see when you supinate like that, oftentimes, you know, you might be extended a little bit, or even just the supination itself can change the axis of the capitate within the lunate here, which is going to be more like this, and potentially, you know, make those angles look increased when they're not. All right, and then just one more lateral here where we have, you know, really nice superimposition of the ulna over the radius, but it's still not the greatest lateral because we don't see the triquetrum all that well, and the pisiform is not projecting with the anterior cortex, you know, halfway between those two. So, so I think this is probably, you know, the best lateral here. Both of these are acceptable laterals, of course, just maybe not quite perfect. So just to show you, there is a bit of variability here in what we're seeing. In those things. So if you have any questions, comments, make sure you leave those down below, you know, or, you know, if you just want to say hi, drop those comments. It really helps boost the algorithm, drive traffic to my channel, which, you know, gives me motivation to make more content like this. Hit the upvote. I'm not really sure that does anything, but it makes me feel good. Send this video to anyone you think might want to watch it. These views are really helpful to help my channel grow. Hit the subscribe button. If you haven't already, hit the bell notification so you don't miss my future videos, and I will see you next time.